sensory tracts. So we'll quickly review, a little bit on the sensory tracts or the sensing tracts, and then we'll move on to the motor tracts today. So what you need to know in terms of the sensory tract, the most important part is that there are three levels of neurons: the first order, the second order, third order neuron. First order neuron, the cell bodies are present in the dorsal root ganglia. Their axons will either synapse at the spinal cord level or they synapse at the level of medulla. The cell bodies of the second order neurons are either present at the spinal cord level or they are present at the level of medulla. The axons of the second order will cross the midline, go to the contralateral side, ascend all the way up to the thalamus, where they are going to synapse with the cell bodies of the third order neuron in the nucleus, which is called the ventro-posterior lateral nucleus of thalamus. And then the axons from the ventro-posterior lateral nucleus of the thalamus are going to pass through the internal capsule to the post-central gyrus, which is the primary sensory area. In terms of the two major tracts in the sensory pathway, one is the dorsal column tract, which is responsible for two-touch discrimination, vibration, and proprioception. The first order neurons are present in the dorsal root ganglia. They enter the spinal cord, ascend in the ipsilateral side all the way up to the medulla, and then they synapse with the nucleus gracilis and nucleus cuneatus in the medulla, which are the cell bodies of the second order neurons. The axons of the second order then cross the midline and ascend through the pons and midbrain and reach thalamus, where they are going to synapse with the ventro-posterior lateral nucleus of the thalamus, and the third order neurons are going to go to the post-central gyrus in the cortex. If you compare this with the spinothalamic pathway, which are the anterior spinothalamic and the laterospinothalamic. Laterospinothalamic is in the lateral white column, responsible for pain and temperature. Anterior spinothalamic is responsible for crude touch and pressure. The first orders again are present in the dorsal root ganglia. They would enter the spinal cord and synapse with the substantia gelatinosa in the dorsal gray horn cells. So the cell bodies of the second order neurons in terms of the spinothalamic pathway are present at the level of spinal cord, and they are mainly substantia gelatinosa cells. The axons of the second order, they are going to cross at the spinal cord level into the contralateral white column, ascend throughout the spinal cord, reach medulla. In the medulla, they are going to join the two tracts, the anterior spinothalamic and the lateral spinothalamic. They would form the spinal lemniscus, and they will reach the thalamus and synapse with the nucleus in the ventro-posterior lateral nucleus of the thalamus, which is the cell bodies of the third order neurons, and from here the axons will go to the post-central gyrus. So the main thing is that the dorsal column are going to cross at the level of medulla, while the spinothalamic is going to cross at the level of spinal cord. So if you have an injury of half side of the spinal cord, below the level of the lesion, the dorsal column is going to be cut on the same side. So it is representing the same side of the body. So you would have ipsilateral loss of two-touch discrimination, vibration, and conscious proprioception, while if your half side of the spinal cord is damaged below the level of the lesion, you would lose contralateral pain and temperature, because the spinothalamic tract is going to cross at the spinal cord level. The other important thing about the lateral spinothalamic tract is that the medial fibers are going to represent the upper limb, while the lateral fibers are going to represent the lower limb. So there is a lamellation of fibers in the lateral spinothalamic tract. That the medial fibers are representing the upper part of the body, the lateral fibers are representing the lateral part, the lateral part of the tract. This is opposite to the fasciculus gracilis and cuneatus. Fasciculus gracilis is representing the lower part of the body and it is present medially. Fasciculus cuneatus, which is representing the upper part of the body, is present laterally because they do not cross. As the lateral spinal thalamic tract fibers are crossing, the medial fibers are from the upper part of the body, while the lateral fibers are from the lower part of the body. This would have implications when we are going to talk about the lesions of the spinal cord. Okay? The other sensory tracts which you should know is the dorsal spinocerebellar tract, and the other one is the ventral spinocerebellar tract. Now, because these tracts are going to the cerebellum, there are only two orders of neurons. The first order, as usual, all sensory tracts, it's present in the dorsal root ganglia. This first order is going to synapse in the dorsal gray matter, in the dorsal nucleus of Clark, and then the dorsal spinocerebellar tract is going to ascend on the ipsilateral side all the way to the medulla, and in the medulla it would pass through the inferior cerebellar peduncle to the ipsilateral cerebellar hemisphere. The anterior spinocerebellar or the ventral spinocerebellar is going to synapse with the dorsal nucleus of Clark, the first order. The second order is going to cross the midline, ascend in the contralateral white column up to the level of midbrain, and then it will pass through the superior cerebellar peduncle to the opposite cerebellar hemisphere. But once these fibers are within the cerebellum, they are going to cross back to the ipsilateral side. So whenever you have a problem with the either cerebellar tracts or cerebellar hemisphere, it would be seen on the ipsilateral side. Now we are coming towards the motor tracts. In terms of motor tracts, what you should know, one is called corticospinal, the other is called the corticobulbar. Now corticospinal means from cortex to the spinal cord. So like when we talked about the sensory tracts, we said first order, second order and third order neurons. Here we are going to talk about an upper motor neuron and a lower motor neuron. Now the upper motor neuron is either coming from the cortex and going to the spinal cord, or it is coming from the cortex and going to the brainstem. Okay? So when it is coming from the cortex and going to the spinal cord, it is called corticospinal. When it is coming from cortex and going to the brainstem is also called bulb. So that's why it can be called corticobulbar. Or sometimes people use the term corticonuclear. So if it is coming from cortex and going to the cranial nerve nuclei, corticonuclear or cortex, coming to the brainstem, corticobulbar, coming from the cortex, going to the spinal cord, this is corticospinal. So this is an upper motor neuron. There is also a lower motor neuron. The lower motor neuron is either present in the anterior gray horn cells and coming out as the spinal nerve supplying the muscle, or in the brainstem it is the cranial nerve, motor cranial nerve nucleus, which is coming out as the cranial nerve and supplying the muscles of head and neck. Okay? So you would have always an upper motor neuron and a lower motor neuron. Upper motor neuron, when we are talking about, it is either corticospinal or corticobulbar or corticonuclear, whatever you want to call as terminology. Lower motor neuron, when we are talking about, it is either the anterior gray horn cells in the spinal cord or the spinal nerve or the peripheral nerve, whichever is supplying to the muscle. And in terms of the brainstem, it could be motor cranial nerve nucleus or the cranial nerve which is supplying the muscles in the head and neck region. So this is showing you the same. Your sensory inputs are going to go to the motor cortex here, the area number 4, which is the primary motor cortex, and from here the upper motor neuron is arising, which is the corticospinal tract. It is going to synapse with the lower motor neuron, and the lower motor neuron is going to influence the muscle. Okay? So the upper motor neuron is corticospinal or corticonuclear, and then you have the lower motor neuron, which is arising from the anterior gray horn cells. So there are also subsidiary descending pathway known as the extrapyramidal pathway. So you have the main motor pathway, which is the corticospinal, which is the pyramidal tract, and the rest of the tracts in the motor pathway are called extrapyramidal. So when you are doing a movement, for example, I'm picking up this, the movements in my hand are very fine movements, but for doing this movement, I need a particular tone in my upper limb, I need a particular posture, because the tone is going to be maintained by my flexors and extensors, and I need a body posture to perform a fine movement at my hand. The posture and the tone is going to be maintained by extrapyramidal pathways. Fine movements are the function of corticospinal pathway. But whenever you would have damage to the upper motor neuron, both pyramidal and extrapyramidal pathways would be involved. You would not be able, clinically, you would not be able to see only extrapyramidal system affected or the pyramidal system affected. Clinically, whenever you would have an upper motor neuron problem, both pyramidal and extrapyramidal system would be affected, and you would have spastic type of paralysis, hypertonia, hyperreflexia, all those features of upper motor neuron. But the function of the pyramidal pathway is to perform fine skilled movements, while the function of the extrapyramidal pathway is to maintain tone and posture. In addition to this, there are two other parts in your motor system. One is called the basal ganglia, the other is called the cerebellum. So what is the function of basal ganglia and what is the function of cerebellum? Now, when you are sitting at rest, do you have any movements? No. Are you doing this? Although what is happening is there is sensory input going at all times to your brain, because you have the environment around it. You're touching a table, you're touching something, you're seeing things. So the sensory information is going directly to your brain, but at rest, you are not doing any movements. The reason for that is that this guy here, the basal ganglia, is sending continuous inhibitory response to the motor cortex in the brain. So because it is sending continuous inhibitory signals to the motor cortex in the brain, at rest you are performing no movements. So when you want to perform a movement, before starting the movement, the cortex is going to send signals to the basal ganglia, and the basal ganglia is going to stop inhibitory discharge for a moment so that you can perform a movement. So basal ganglia is important in initiation of a movement because it needs to stop its continuous inhibitory discharge to the cortex so that you can start the movement. Now, if there is a problem with the basal ganglia, then what would happen? Either this inhibitory discharge will increase or this inhibitory discharge would decrease. If you have this inhibitory discharge increasing, it would be very difficult to start any movement. Okay? So it would be very difficult to start any movement if there is an increase in the inhibitory discharge from the basal ganglia to the cortex, like what happens in Parkinsonism. That when you see these patients, they have difficulty in moving, they are rigid, and they shuffle in the gait, and this is a hypokinetic disorder. That means it is very difficult to start any movement. On the other hand, there could be basal ganglia problem which will result in decreased inhibitory discharge to the cortex. So at rest you would start to have involuntary movements like Huntington's chorea. So in Huntington's chorea you start to have dancing like involuntary movements. Why? Because the inhibitory discharge from the basal ganglia to the cortex decreases. So Basal ganglia is important in the initiation of movement. It is sending inhibitory discharge to the cortex so that at rest you have no residual movements or extra movements. But in a damage to the basal ganglia, like Parkinsonism, you might have very difficult time to start a movement and you will become very rigid and the muscles will be, like this, rigid, but there is no paralysis. It's that you are unable to start the movement, okay? Or you would have involuntary movements in case of less inhibitory discharge from basal ganglia to the cerebral cortex. Yes?
So once we start the movement, is the lack of inhibition still there?
Yes.
So from the initiation till the progression of movement, we inhibit the basal ganglia.
Yeah, so it is going to be, when you want to stop the movement, the inhibitory discharge is going to start again. So you would have in between time when you are starting the movement and you are finishing the movement. That is the function of the basal ganglia. Okay? Now compare this with cerebellum. Cerebellum is a comparator. That means it is going to get sensory information from anterior spinocerebellar, posterior spinocerebellar, and all the sensory tracts, and then compare this sensory information with the intended movement. And then when you are performing that movement, the cerebellum is going to send corrective signals to the cortex. So cerebellum is important in correction of your movements. So for example, I asked a patient to touch the nose and touch the finger nose test. And I keep on changing the distance. Each time when my cerebellum is normal, I can correct the distance between the nose and the finger. But if there is a cerebellar problem, these patients would not be able to correct the distance between the nose and the target. So if you keep on changing the target, the patients with the cerebellar disease would not be able to get the distance rightly. They cannot correct the movement during the real time. So if you put up the electrodes into the cerebellum, you would find that the cerebellum is electrically discharging when you are performing a movement, while the basal ganglia is discharging before you initiate the movement. So the function of cerebellum is to compare sensory input with the intended movement and then perform corrective actions while you are performing a movement. Okay? Clear? So now, if you have corticospinal pathway, the upper motor neuron damage, then you would have the paralysis of fine movements. You would not be able to perform fine movements, and because of the upper motor neuron, you would have spastic type of paralysis, hyperreflexia, and increased tone. If you have lower motor neuron paralysis, you have flaccid type of paralysis, loss of tone, loss of reflexes. If you have basal ganglia problem, there would be no paralysis, but there would be difficulty in initiating the movement, rigidity, these type of features, tremors might be there. So those would be the features in basal ganglia. In cerebellum, you would have discoordination. Discoordination because you would not be able to correct the movements during real time. So if you do repeated movements, they will become discoordinated. If you change the distance, there would be dysmetria. You would not be able to correct the movements there. If you move the eye cannot correct its, its position. So you would have nystagmus. So nystagmus is because of the inability of the eye to correct its movement, and it is also controlled by cerebellum. So basal ganglia, initiation of the movement, cerebellum during real time, correction of the movement. So you can see these features and you can define which part of the motor system is affected. Okay? Clear? So corticospinal tract, as I said, is a pathway which forms the pyramidal tract. The upper motor neuron extends from the cerebral cortex to the spinal cord. That's why it is called corticospinal. Principally regulate the distal musculature in the limbs and the trunk, because that's responsible for fine movements. Corticobulbar tract is a pathway of upper motor neurons extend from the cerebral cortex to the motor cranial nerve nuclei in the brainstem, and because brainstem is called bulbar, that's why it is called corticobulbar tract, principally for regulating the muscles of head and neck. So now we are coming to the corticospinal tract. It's a massive bundle of fibers about 1 meter long, forming a direct pathway from the cerebral cortex to the spinal cord. Originate from pyramidal cells in the neurons of the cortex, and the three major areas from where the pyramidal tract comes out is the primary motor cortex, 1/3 of the fibers, premotor and supplementary motor cortex, 1/3 of the fibers, and primary sensory cortex, 1/3 of the fibers. So these are the three areas through which there is origin of the corticospinal tract. Primarily concerned, as I said, in the distal muscles of your limbs, mainly fine movements in your hand. So important for precise, skilled, learned movements. So if we see here, this is the corticospinal tract arising from the cortex, and in the cortex also you have representation of your body, and the representation is called homunculus. Homunculus is your representation of the body. You can see it here. Your hand has much bigger representation as compared to your trunk, because most of the skilled movements are going to happen in the hand. And your leg is basically represented on the medial side of the cerebral cortex. The lateral side is representing the upper part of your body. The lower part of your body is represented on the medial side of the brain. It has an important implication because the lateral side of the brain is supplied by another artery, while the medial side of the brain is supplied by another artery. So if you have a stroke caused by the middle cerebral artery, which supplies the lateral part of your brain, you would have the effect in your hands and your face, but your legs would be spared. While if the anterior cerebral artery, which supplies the medial part of your brain, then your legs would be paralyzed and this part would be spared. So the arterial supply also has a relationship with which part of the brain is supplying what. Okay? So from the cortex, the corticospinal tract is going to arise. It is going to pass through this small space which is called the internal capsule, and then it will enter into the midbrain, and it will pass through the interior part of the midbrain, which is called the cerebral peduncle. Now, once it passed through the cerebral peduncles, it would pass through the anterior part of the pons, which is called the basilar part of the pons, and then when it reaches the medulla, it is going to form this elevation which is called the pyramid. The lowermost part of the medulla, where the medulla is joining the spinal cord, 85% of the fibers of the corticospinal tract are going to cross the midline, and they are going to descend in the lateral white column, forming the lateral corticospinal tract. While 15% of the fibers will remain ipsilateral, descend in the anterior white column, they will form the anterior corticospinal tract. Even the fibers of the anterior corticospinal tract at their particular spinal cord level, they are going to cross the midline and synapse with the lower motor neuron. And this lower motor neuron, as we said, is present in the anterior gray horn cells of the spinal cord. So what you are seeing here is that 85% of the fibers are crossing at the level of junction between the medulla and the spinal cord. So if you have a damage of the spinal cord at any particular level, T4, T5, below the level of the lesion, you would have the lateral corticospinal tract cut. So you would have an ipsilateral spastic type of paralysis. It would not be contralateral. But if you have above the medulla anywhere damage to the corticospinal tract, contralateral side of the body would have the spastic type of paralysis. So if there is a spinal cord level injury, below the level of injury, you would have spastic paralysis on the ipsilateral side. If it is anywhere above the medulla and you have damage of the corticospinal, there would be contralateral spastic type of paralysis or upper motor neuron type of paralysis. So this is an important concept to. Okay. So this is, everybody understands corticospinal tract? Yes, go ahead.
So can we say that the right cerebral hemisphere controls the movements of the left side?
Left side. So right cerebral hemisphere controls the movement of the left side, the left cerebral hemisphere controls the movement of the. Okay. Now we are going to talk about some of these other motor tracts. So we have talked about the corticospinal, which is arising from the primary motor cortex, premotor cortex, and the primary sensory cortex. You see it goes down all the way to the lower part of the medulla, where it is going to cross to the opposite side. So this is the corticospinal tract. There are three other tracts which in the motor system you should know. One is the reticulospinal, the other is the rubrospinal, and third one is the vestibulospinal. Reticulospinal, rubrospinal, and reticulospinal. They are together called as extrapyramidal pathway. Corticospinal is the pyramidal pathway, the other three are extrapyramidal pathways. Now if you see this reticulospinal, it mainly originates bilaterally from the reticular formation in the brainstem. And it descends down to in the anterior white column, synapse with the lower motor neurons on both sides. So this is the reticulospinal tract, and this reticulospinal tract is responsible for facilitating flexor as well as the extensor tone. So it facilitates both flexor and extensor tone. On the other hand, the rubrospinal tract arises from the red nucleus which is present in the midbrain. As it arises from the red nucleus from the midbrain, it crosses the midline, descends in the lateral white column along the side of the corticospinal tract, synapse with the lower motor neuron on the opposite side. The major function of the rubrospinal tract is to facilitate the flexor tone. So it facilitates the flexor tone, inhibits the extensors. So it is facilitatory to flexors. Reticulospinal was facilitatory to both extensors and flexors. The vestibulospinal tract, on the other hand, arises from the vestibular nuclei, descends down in the anterior white column, synapse with the ipsilateral and the contralateral lower motor neurons. The major function of the vestibulospinal tract is to facilitate the extensor tone, and it inhibits the flexors. So these are the extrapyramidal pathways. If you know this much about them, this is good enough. There might be some other pathways you would see, like tectospinal tract. This is for visual reflexes. There is an olivospinal tract. You don't need to know. We don't know even the function of the olivospinal tract. So these are, some of the motor tracts besides the corticospinal. Corticospinal you should not forget. These, if you don't know the pathways, doesn't really matter. You just need to know a little bit of their function and the names. Yes?
Do they have any synapse with the cortex?
There is some descending pathways which are going to synapse with the red nucleus or vestibular nuclei, but you don't need to know that. That's quite a bit of detail. Okay, we have already talked about this. We said the upper motor neuron is arising from the cortex all the way down as a corticospinal or the extrapyramidal tract is going to synapse with the lower motor neuron, and the lower motor neuron is going to supply the muscle. If you have damage to the lower motor neuron, either in the anterior gray horn cells or the spinal nerve or the peripheral nerve, you would have the lower motor neuron type of lesion, which means flaccid paralysis, loss of tone, reflexes are gone, and you also would have the muscles shrinking. If you have the upper motor neuron affected, the corticospinal or rubrospinal or whatever, the upper motor neurons are affected, then you would have hyperreflexia, you would have increased tone, you have the spastic type of paralysis, and the muscle mass will remain intact. So those are the signs of upper motor neuron type of paralysis. Yes?
The Babinski effect, how will it relate to the upper motor?
So it is also an upper motor neuron type of thing. Babinski sign, what you should know, is that it's present in infants also. You know, the young children, before the 1 year of age, before they start walking, you have a positive Babinski sign. Because you touch them, you know, on the lateral side of their sole, and their fingers will fan out like this. The reason why it was there, because the corticospinal tract requires a year for myelination. So because the corticospinal tract is not myelinated in infants, you have a positive Babinski sign. Now in case of adults, if you have a positive Babinski sign, this means an upper motor neuron type of lesion. There is a damage to the corticospinal tract. So if there is a damage to corticospinal tract, you would have positive Babinski sign. Similar to normals is downgoing toes. If you have upgoing toes, this is a positive Babinski sign. This means that there is damage to the corticospinal tract, or in case of infants, there is demyelination, or there is no myelination, not demyelination, there is no myelination or less myelination of the corticospinal tract. Okay? Clear?
The lower has no effect. The lower there's no effect because you have no reflex.
Lower motor neuron will have no effect on Babinski sign. Babinski sign is positive only when you have a problem with the corticospinal tract. Okay? Yes.
What does CFP mean?
CFP is the common final pathway. So for upper motor neuron also, the common final pathway is the lower motor neuron. Directly upper motor neuron cannot supply the muscle. It has to synapse with the lower motor neuron. So that is the common final pathway to the muscle. Yes?
So doctor, if we have upper motor lesions, can we know which nucleus is affected, like a reticulospinal or?
No, as I said, you cannot differentiate between pyramidal and extrapyramidal tracts injury. Usually clinically, when you have damage to the spinal cord, both pyramidal and extrapyramidal would be affected. So you cannot say this is only pyramidal tract damage, or you would have Babinski sign positive, and you would also see hyperreflexia, spastic type of paralyses, all those things. Okay? Okay. So when you get the spinal cord injury or any injury to the brain, for a period of time, the spinal cord or the brain will remain in shock. So whenever there is damage to the neurons or injury to the neurons, they stop discharging their electrical signals for a while. Okay? So if you have a stroke in the brain, or you have a spinal cord injury because of a road traffic accident, for a while the spinal cord below the level of the injury is going to stop electrical impulses. So if the electrical impulses are going to stop from all the neurons, what would happen? What type of paralysis? Lesser type of paralysis. If you would have, a spinal shock because of the spinal cord injury, there would be few hours to few weeks that the neurons will stop discharging their electrical activity. That means that below the level of the lesion, you would have flaccid type of paralysis. So there is going to be no movement. It would be bilaterally, you would see flaccid type of paralysis. So if you go and try to do a neurological examination right after a spinal cord injury, you would not find specific neurological deficit because the spinal cord is in shock. So spinal cord remains in shock for few hours. It can go up to few weeks that the patient may remain in the spinal shock. So how would you know that the patient is in spinal shock or not? Usually we perform an anal reflex. What is an anal reflex? We put up a finger into the backside of the patient and we try to clamp the tip of the penis or the clitoris. If there is a contraction of the anal sphincter, this means there is no spinal shock. If there is no contraction of the anal sphincter, we know that the patient is in spinal shock, and it might take, yes. Coma is a state of unconsciousness, and that is assessed through Glasgow Coma Scale. There is a Glasgow Coma Scale through which we identify the level of consciousness. Here, patient might be conscious, but his lower part of the body is flaccidly paralyzed because it is in the spinal shock. So whenever there is an injury to the brain tissue or the nervous tissue will stop its electrical activity for a while. So if it is a spinal cord injury, there would be a spinal shock for few hours, extending from few hours to few weeks. So you need to check for the spinal shock before you do the neurological examination, because you would not find any deficits. It would be just flaccid type of paralysis all the way down. Okay, so you don't want to do a neurological examination to look for a neurological deficit when the patient is in spinal shock or in brain shock whenever the brain is injured also. So what you would see, signs are slow heart rate, low blood pressure, because of the autonomic fibers are also going to stop discharging. So you would have slow heart rate, low blood pressure, flaccid type of paralysis of the skeletal muscles, loss of somatic sensations. There would be no sensations on the below the level of the lesion, urinary bladder dysfunction. Spinal shock may begin within an hour after injury and last from several minutes to several weeks, not months, but weeks, after which reflex activity gradually resumes. It is similar to like when you open up the abdomen and you touch the abdominal viscera, you would have paralytic ileus. The intestine will stop moving for a while after surgery. And you keep on listening the gut sounds to see if the gut is moving before you start feeding people. So it takes a while for the gut to resume its electrical activity and peristalsis. Similarly, the spinal cord, once it is injured, it is going to take a while before it starts to regain its electrical activity. So usually it is better to perform the neurological examination after the patient is out of the spinal shock. Then you would get the real neurological deficits because of the injury. Okay. We can stop here. Okay, we can stop here. We can do the lesions of the spinal cord next time. Yes.